All right, let's get right into it. We're here to talk about one of the biggest shifts in asthma management that we've seen in years. And if you're a practicing pharmacist, this is information that's going to change how you counsel your patients, probably starting your very next shift.
So let's start with a question that really gets to the core of this whole change. The blue inhaler, the SABA reliever. It's been the go-to for decades, right? But what if our reliance on it, what if our patients' reliance on it, is actually putting them in danger?
Well, the answer to that question is a resounding yes. The 2023 GINA guidelines made it official. The paradigm has shifted. Just relying on a short-acting beta agonist, a SABA, to manage asthma, that's no longer the standard of care. This one change pretty much upends everything we thought we knew about treating mild asthma.
Okay, so here's how we're going to break it all down. First, we'll dig into the why behind this big SABA paradigm shift. Then, we'll cover the new foundation of therapy, which is inhaled corticosteroids. We'll look at stepping up therapy, your absolutely critical role in counseling on technique and adherence, some major warnings to watch for, and then we'll wrap up with how you can really impact patient care.
So first things first, let's really get into the why. Why this huge change after so many years of doing things the same way? Well, it all boils down to one word: risk.
This number right here, this is your new immediate red flag. A patient who is using more than 2 SABA reliever canisters a year, that is a massive sign of poor asthma control. If you see that on a patient's profile, it's time to step in.
And the evidence is just, well, it's undeniable at this point. When a patient overuses their SABA, yeah, they get that immediate symptom relief, but it's dangerously masking the real problem, the chronic inflammation in their airways. So they feel better for a minute, but their disease is quietly getting worse, and that's what leads to these severe flare-ups and, tragically, even death.
Okay, so if SABA-only therapy is out, what's in? What's the new cornerstone? It's all about shifting our focus to controlling that underlying inflammation.
The answer is inhaled corticosteroids, or ICS. And the big news here is that these are not just for severe asthma anymore. The new guidelines put ICS right at the center of treatment for all levels of asthma because they're the only thing that actually treats the root cause, the inflammation.
So, for your patients with mild asthma, this basically means one of two strategies. The preferred way, what they call track 1, is using a combination ICS/formoterol inhaler, but only as needed. This is brilliant because every single time the patient reaches for relief, they're also getting a dose of that crucial anti-inflammatory. The other option, track 2, is more traditional, a daily low-dose ICS controller with a SABA just for those rare breakthrough symptoms.
Now, when you're counseling on ICS, the most common local side effects are things like thrush or hoarseness. But the great news is they're almost completely preventable. The single most important counseling point is this: tell them to rinse their mouth with water and spit it out after every single use. It's so simple, but it makes a world of difference for adherence.
But what about the patients who need more than that? For folks whose asthma isn't controlled on that foundational therapy, let's quickly walk through the next steps on the treatment ladder.
This chart lays out the GINA step-up approach really nicely. You see, step 1 is that new foundation we just talked about, as-needed low-dose ICS/formoterol. If that's not cutting it, we move to step 2, a daily low-dose ICS, usually combined with a LABA, a long-acting beta agonist, for extra bronchodilation. Still not enough, step 3 bumps them up to a medium-dose ICS/LABA. At step 4, we're getting into more severe asthma. We go to a high-dose ICS/LABA, and we add a LAMA, a long-acting muscarinic antagonist, which gives us a third mechanism of action. And finally, if they're still uncontrolled, step 5 is where we refer them for advanced therapies like biologics. It's a very logical progression.
Okay, understanding the drugs is one thing, but let's be real. This next part is where you, as a pharmacist, can have the biggest impact. It is all about technique and adherence.
This is so critical to remember. Not all inhalers work the same way. For a pressurized MDI, the patient needs a slow, deep breath that's perfectly timed with pressing the canister. But for a dry powder inhaler, a DPI, they need a quick, forceful breath to get the medicine out. You can see how easy it is for patients to get this wrong, so you have to check their technique and make sure they know the answer to the question: is it slow and deep or fast and forceful?
And now for a number that is, well, it's just shocking. Most patients will fill that first prescription for their controller medication, but the adherence rate for the next fill plummets to just 36%. That is a gigantic gap in care.
It means that almost 2/3 of your patients are not using the one medication that's supposed to be preventing their asthma attacks.
So how do we fix this? We do what we do best. We watch their technique every single time. We simplify their regimen whenever possible. We make sure they have a written action plan. And maybe most important of all, we explain why they need that controller every day, even when they feel good. And of course, we teach them how to manage those simple side effects, like rinsing their mouth. These are the actions that directly fight back against that terrible 36% number.
Okay, next up, let's cover some of the most critical warnings that have to be on your clinical radar for every single asthma patient you see.
First, let's talk about montelukast. It carries an FDA-boxed warning for a reason. We are talking about serious neuropsychiatric events. This is not a minor, rare side effect. We're talking agitation, aggression, depression, even suicidal thoughts. This is an absolutely essential counseling point for any patient starting or refilling this medication.
Second, and this is a never event, it should never ever happen, LABA monotherapy is absolutely contraindicated in asthma. Using a long-acting beta agonist without an inhaled corticosteroid has been proven to increase the risk of asthma-related death. They must always be prescribed together in a combination inhaler, period.
And just a few other key things to keep in your back pocket. Remember that SABA overuse can cause that shaky feeling, tachycardia, and tremors. Long-term systemic steroids, of course, come with a whole list of problems like osteoporosis and high blood sugar. And a really practical tip for flu season, the live attenuated nasal spray vaccine is a no-go for patients with severe asthma.
All right, let's bring it all home. Let's summarize how you can take all this information and put it into practice in your daily workflow to make a real, tangible difference for your patients.
If you take away nothing else today, please remember these 3 actions. Number 1, flag any patient using more than 2 SABA canisters a year. That's your signal to intervene. Number 2, demonstrate and check inhaler technique with every patient, every time. And number 3, counsel on why that ICS therapy is so vital and teach them how to manage those simple side effects. If you do just these 3 things, you will dramatically improve asthma outcomes.
You know, this knowledge is only powerful if you actually put it into action. So think about it for a second. What's one thing you're going to do differently with the very next asthma patient you talk to? By flagging those risks, teaching proper technique, and empowering patients with knowledge, you play such an indispensable role in helping them breathe easier and live fuller lives. Thanks for your time.